Okay, so let's talk about male stress urinary incontinence. So, stress urinary incontinence is different from urge urinary incontinence. Stress incontinence happens when you cough, sneeze, pick something up, bend down to get out of a car. That increased abdominal pressure causes the urine to come out through the sphincter. Usually, this happens after some type of prostate surgery, either prostate removal for cancer or a procedure to open up a channel in the prostate to help somebody urinate better. This is usually a side effect of that. Now, urge incontinence is the sensation that you need to run to the bathroom urgently, and if you don't make it there quickly enough, you might leak a little bit. That's a totally different beast and has totally different treatment options. Some men have both, but they need to be tackled somewhat separately. Here, we're just going to talk about stress incontinence. So for stress incontinence, the first line of treatment is Kegel exercises. This is basically pelvic floor muscle strengthening to help support that sphincter. This is shown to be very effective, but only in the first year after the prostate procedure. Once you're over a year out, you're unlikely to get any benefit from Kegel exercises. After a year, if you're still leaking, the basic treatment is pads, diapers, and clamps or different devices to help squeeze the penis shut. Now, this isn't really a treatment that's going to fix the leakage. This is more about how to live with the leakage, which unfortunately for a lot of men is their reality. Now, if you're over a year out from one of these procedures and you're still leaking and you don't want to live with it, you want to have it fixed, basically the only treatment options are surgical. There's no medication that's going to help with this type of leakage. And the two main surgeries are a sling and a sphincter. So I'll talk about a sling first because it's the simpler one. So a sling is basically a mesh synthetic material that's surgically implanted right beneath the urethra to basically act as a backboard to support it, to prevent it from moving when the intra-abdominal pressure increases. This is placed through a transperineal incision, meaning an incision in the skin between the scrotum and the anus, probably about that big. And through that incision, we dissect down to the urethra and put the sling in place. And the surgery takes roughly an hour or so, depending on who's doing it. It's generally always an outpatient surgery, meaning you go home the same day and the sling starts working right away. You immediately feel significantly drier. It's a great option with low risks of major complications. Rates of infections and things like that are very low, and it's very easy to use. The patient doesn't have to interact with the device at all. It's basically always working. Now, the downside of a sling is that it's really only good for mild incontinence. It's not going to be enough support for somebody who has severe incontinence. Now, the urology guidelines say it's good for mild to moderate incontinence. Now, how exactly you define mild to moderate is up for debate. In our research that we've done and published in what we call moderate incontinence, we found that the slings are usually not very successful in getting patients to be satisfied with their level of dryness. And so we generally recommend an artificial urinary sphincter for patients with moderate to severe incontinence and only doing slings in men with mild incontinence. Now, some would disagree with us, and I say that for moderate incontinence, it is an option as long as the patient understands that they might still be leaking afterwards. And if that's the case, there still would be a candidate to have an artificial urinary sphincter placed, but then they're undergoing two surgeries instead of one. So the moderate is sort of a gray zone depending on who you ask. The other gray zone with the sling is radiation. Classically, men who've had their prostate radiated for cancer, it's thought that the sling is less likely to be effective and more likely to have complications. Now, that's been sort of put more to debate in recent years, and a lot of urologists will offer slings to men with history of radiation as long as the patient understands that they're at higher risk potentially for complications like erosion or just not being happy with the results of the sling. I generally recommend against slings for men with radiation, but I recognize that some men, the sphincter is really not an option for them, and the sling could be an option as long as they understand those risks. The other gray zone for slings has to do with men who still have a prostate. meaning their prostate wasn't removed for cancer. They generally had a procedure like a TURP to help open up a channel in their prostate to help them urinate more easily. A lot of urologists, myself included, say that if the prostate is still there, you don't get as much push from the sling and you don't get as good of a result. Some say they still get fine results with the prostate still there, but in my practice, I tend to recommend people, if you still have a prostate, to get a sphincter. So the artificial urinary sphincter is a little bit more complicated. You still have that transperineal incision in the skin between the scrotum and the anus to get down to the urethra, but once you're there, you have to dissect completely around the urethra to place a cuff that goes around it. Now, the cuff, 99% of the time, is filled with saline at a specific pressure that squeezes the urethra shut. Now, that keeps you dry, but when you want to urinate, you have to push a button in the scrotum to open the cuff. Your bladder still fills up like normal, and you still get the sensation to urinate, but then you have to interact with the device, find this pump that goes in the scrotum next to the testicles, and squeeze the button. And by squeezing the button, you're pushing the fluid out of the cuff and into a small reservoir, basically a balloon, that gets put in your pelvis near your bladder through a second incision. So it's a little bit of a more involved procedure, but it still takes only 90 minutes or so, depending on who's doing it, and you still go home the same day, but you have slightly higher risks, right? So an artificial urinary sphincter does have a real risk of a device infection, 2 to 3% depending on the series. And if there's an infection, it doesn't just mean you take antibiotics for a week and it goes away. That means this is a nightmare. You're going to have another surgery to have the device removed. Also, the sphincter can malfunction over time, right? It's a simple mechanical hydraulic system. So just like a car, it can break over time. And the average lasts about 8 to 10 years. So if you have a device that's no longer functioning, you can leave it alone. It's not going to cause any problems. You're just going to continue to leak. And that's what happens in a lot of cases, especially if at that point the male is a lot older and they just want to live with it. But if you're still bothered by the incontinence at that age, then you have to have another surgery to remove the old sphincter and put a new one in. So again, you have all the risks of the second surgery brought in. The other issue with the sphincter is that constant pressure on the urethra can lead to an erosion, or basically a hole in the urethra over time, especially in men with risk factors like radiation or prior urethral surgery. Now, the risk is still only 2 to 3%, but it goes up with time and it can happen at any point. So the sphincter has that downside of more risks of complications, of device malfunction, and the patient has to learn how to interact with the device, right? This is not an option for somebody with severe dementia or somebody with no dexterity, because the patient needs to be able to tell that it's time to go to the urinate and find the device in their scrotum and push the button to open the cuff. Now, with all those downsides said, the sphincter is still the gold standard. It's been in use for over 50 years and it works very well, especially in men with severe incontinence. They are likely to get almost completely dry from this device and report a huge improvement in quality of life. So much so that even in those percentage of men that have had a major complication like an erosion, even after they've recovered from that, the first question they ask when they come back to the office is, when can I have another sphincter put back in? Because their quality in life was so much improved by having the sphincter in. So it is still a great option despite those risks. They're relatively uncommon, but they're still real. So if you're a man with stress incontinence who has been over a year out from your surgery and it's not getting any better at this point, your options are basically to live with it or consider a surgical intervention. And so if you don't want to live with it, you should make an appointment with a urologist who does these procedures and talk about the risks and benefits of each option with your surgeon and for your specific situation.